First, an update on the Mpox outbreaks in Africa. More than 18,000 suspected cases of Mpox have been reported in the Democratic Republic of the Congo so far this year, with 629 deaths. That includes more than 5,000 cases and 31 deaths from the eastern provinces of North and South Kivu, where the new clade 1b strain has been spreading. The number of reported cases of clade 1b has been rising rapidly for several weeks. Fortunately, relatively few deaths have been reported in recent weeks. In addition, 258 cases of clade 1b have been confirmed in Burundi, $10 million to the response, and for his leadership on the response. I assured him of WHO's full support, together with the Africa CDC and other partners. I also had the opportunity to meet with the United Nations country team, where we discussed coordination of the Mpox response among UN agencies under the government's leadership. We discussed the critical importance of clear communication with people at risk of Mpox and strong engagement with communities and local partners. I also met with global and local health partners to discuss scaling up routine immunization for other diseases, including polio, measles, and malaria, and mobilizing frontline polio workers to support the Mpox response. WHO is working to accelerate access to and delivery of vaccines. The manufacturers of the 2 vaccines submitted their applications for emergency use listing last Friday, the 23rd of August, and we're working to review those applications as fast as possible. The safety and efficacy of vaccines are our highest priority. We will not take shortcuts. The 2 main buyers of vaccines for low-income countries, Gavi and UNICEF, require WHO emergency use listing to buy vaccines for use in countries that have not issued their own national regulatory approval. Last week, I gave Gavi and UNICEF the green light to proceed with procuring vaccines in parallel with the EUL process. However, WHO emergency use listing is not a barrier to vaccines being deployed in DRC. DRC's medicines regulator approved both vaccines in June of this year, and the government has requested bilateral donations of vaccines from high-income countries with large stockpiles. Together with the Africa CDC, WHO has also helped to secure donations from the European Union and some of its member states. WHO is working with the Africa CDC, Gavi, UNICEF, CEPI, and HERA to set up a coordination mechanism to allocate the donated vaccines and increase access in affected countries. Yesterday, we also invited manufacturers of Mpox diagnostics to submit an expression of interest for emergency use listing. Today, we have received the first expression of interest. Over the past 2 days, we have also convened a meeting of researchers to identify research priorities and to foster a coordinated and collaborative approach to the development of vaccines, diagnostics, and therapeutics. It's vital to stress that although vaccines are a powerful tool, they are far from the only tool. There are many things that WHO and our partners are doing to prevent and diagnose infections and treat the sick. The outbreak of clade 1b Mpox is occurring in one of the poorest and most insecure regions of DRC, complicating the response. Despite these challenges, hundreds of WHO personnel are on the ground in DRC and the other affected countries, working with our partners to stop transmission and bring these outbreaks under control under the government's leadership. And with the government's leadership and close cooperation between partners, We believe we can stop these outbreaks in the next 6 months. But what this region of DRC needs more than anything else is a political solution to the long-running insecurity, especially in the eastern DRC. Now to Gaza. On Sunday, WHO and our partners will begin a polio vaccination campaign in Gaza, in which we aim to reach more than 640,000 children under 10 years of age. The campaign will involve 2 doses of vaccine given in 2 rounds, 4 weeks apart. More than 1.2 million doses of vaccine have been delivered to Gaza, and 400,000 more doses will arrive soon. We have trained more than 2,180 health workers and community outreach workers to provide vaccination and inform communities about the campaign. Our aim is to reach at least 90% vaccination coverage during each round of the campaign to stop the current outbreak and prevent the international spread of polio. The campaign will be delivered in a phased approach over 3 days in each round, starting with Central Gaza, followed by South Gaza, and then North Gaza. I thank the Palestine Ministry of Health, UNICEF and UNRWA, and others for their partnership in this campaign. I welcome the commitment to humanitarian pauses in specific areas to allow the vaccination campaign to be carried out. Due to insecurity, damage to roads and infrastructure, and population movement and displacement, 3 days in each area is unlikely to be enough to achieve adequate coverage. Vaccination coverage will be monitored throughout the campaign, and it has been agreed that vaccination will be extended by 1 day wherever necessary. The vaccination teams must be protected and allowed to conduct the campaign safely. We urge all parties to ensure their protection and that of health facilities and children. Humanitarian pauses are welcome, but ultimately, the only solution to safeguard the health of the children of Gaza is a ceasefire. The best medicine is peace. Now to Sudan, where fighting has now been continuing for 500 days. Hospitals are shutting down, and life-saving supplies are running out. Outbreaks of cholera, dengue, malaria, and measles are taking lives and putting further pressure on the health system. WHO is particularly concerned about the situation in El Fasher and surrounding areas in North Darfur, with famine already reported from the Zamzam camp. WHO has verified more than 100 attacks on healthcare since the conflict began. The recent attack on El Da'in Hospital in East Darfur killed 16 civilians, including children and a nurse. The attack damaged the dialysis and gynecology departments and stocks of life-saving vaccines and other supplies. WHO is working with UNICEF and partners to support the Federal Ministry of Health as it responds to multiple health challenges. This includes rolling out essential vaccines to children and providing technical, operational, and financial support to the cholera response. Preposition cholera and other essential medical supplies helped jumpstart the response. WHO recently deployed 51,000 doses of oral cholera vaccines in Kassala State, which has a high number of cases. The International Coordinating Group on Vaccine Allocation has approved a request for more than 450,000 doses to be sent to scale up the vaccination campaign in Kassala State. Last week, 5 trucks from WHO and partners delivered over 175 tons of health supplies. These supplies, including medicines, diagnostic materials, and nutrition supplies, will be used by humanitarian partners to provide emergency health care, treat infectious diseases, and help alleviate the threat of malnutrition. But much more is needed to stop diseases from spreading and avert famine in parts of the country. A ceasefire and unhindered humanitarian access is the best way to stop the health crisis worsening. Finally, earlier this week I was in Brazzaville for the annual regional committee meeting of the WHO Regional Office for Africa. The committee nominated a new regional director, Dr. Faustin Ndugulile of Tanzania, to succeed Dr. Shidi Moeti, whose second term ends in January next year. I congratulate Dr. Ndugulile on his nomination, and I thank Dr. Moeti for her 10 years of leadership, dedication, vision, and commitment to serving the people of Africa. The regional committee also hosted a pledging event for the WHO investment round, which aims to mobilize the sustainable funding we need to implement our work over the next 4 years. I have asked every member state to contribute according to its means and every partner. I'm deeply grateful to the 14 African member states and partners who pledged more than $45 million to the investment round. Africa is leading by example. I call on other regions to follow. Fedila, back to you.
Thank you, Dr. Tedros. Now I would like to open the floor to journalist questions. If you want to ask a question, raise your hand using the raise your hand icon and unmute yourself. First journalist is Helen Branswell from STAT. Helen, can you hear me?
Hi, Fidela. Thank you very much. Yes, my question relates to Mpox vaccines. At the last press conference, Maria Van Kerkhove suggested that countries should coordinate with WHO if they are giving donations of vaccine, because WHO needs to have a sense of how much vaccine is being offered and where. Do you have an updated number at this point about how many doses have been donated or are being donated? Thank you.
Dr. Van Kerkhove?
Yeah, thanks very much. I also have, we have some people online who I'm sure will want to supplement this. So thanks very much, Helen, for the question, and thanks for flagging the request that we had made to work with us to set up this allocation mechanism. As the DG mentioned in his speech just now, we are setting up this access and allocation mechanism, working with a number of different partners on this. It's really important that we coordinate because there are a limited number of supplies so far, and these vaccines need to reach the countries at risk. They need to be used in a targeted way in the DRC, in Burundi, in countries that are facing this upsurge. And that's really critical at the moment. But we are working with partners to set up this allocation mechanism, looking at the donations, not only where they're coming from, which vaccines, when they expire, when they might get into country, the conditions, all of that needs to be coordinated so that we can work with countries, so that the countries take the ownership of the use of these vaccines and they use them when they become available as part of the response. So maybe I could pass to my colleague, Tim, who can answer more on that.
Oh, thank you, Maria, and thank you, Helen. Yeah, I think we have a good understanding about the existing pledges that have been expressed by different countries and entities for this response. However, pledges need to be turned into donation following then the discussion and agreement and negotiation around that. So these pledges will turn into donation at different time frames, and we have a good understanding on the different quantities that will be available in the coming weeks and months, but also pledges that will probably materialize towards in the next 2 to 3 months. And I think that's important then to match what we know will be coming down that pipeline to match with the different needs on the ground as the countries are preparing now for different vaccination strategies. Thanks.
Thank you. Just to give you the exact title of Tim Nguyen, his unit head high impact events preparedness. Now I would like to give the floor to Emma Farge from Reuters. Emma? Emma, can you hear me?
Yes, the unmute button took a second to come up. I wanted to ask about the polio vaccination campaign in Gaza, please. I'm wondering how satisfied you are with the plans for a pause. I understand that not all of Gaza will be subject to a pause. So is that going to be workable from your point of view, or are there shortcomings with the plan? And secondly, just a compliment, please, could you give a little bit more information about the company that's expressed interest in the Mpox vaccine? Thank you.
Thank you, Emma. I would like to invite Dr. Pieperkorn to take your first question. Dr. Pieperkorn?
Thank you very much. So first of all, greetings from Gaza, greetings from the WHO office in Derbella. And I think as we speak, the technical team, the technical polio team is meeting here in the WHO office where we have established an emergency operation center. I just actually had a meeting with my UNICEF colleague as well. And it is actually inspiring. I want to say inspiring to see it's the people from the Ministry of Health, WHO, UNICEF, UNRWA, and other partners, many other partners, etc. And it was when I arrived up till late yesterday evening, etc., and the whole day fine-tuning the campaign. Now, I think it's a very good question. So, are we happy? Are we confident with this campaign? That's actually basically what you are saying. Let me be very clear. It's not ideal. But nothing is ideal in Gaza, and I think we have an agreement where we all agreed as technical partners that we can work with, and we think it is feasible if all the pieces of the puzzle are in place. And I think the DG was very clear on those pieces of that puzzle. We will start with central Gaza, then we move to the south, then we move to the north. Everywhere we do 3 days of campaign. Every day, and the polio program, we also got some other polio experts in from WHO and UNICEF also to assist. This is one of the programs which analyzes very well. They analyze every day, we analyze where are we, what went well, what went wrong, where are we missing children, where are we doing well. So this is a combination, a combination. Unfortunately, I mean, and that is, I think, we cannot do house-to-house campaign. That's what you would normally want. For whole reasons we know we cannot do house-to-house. But what did we do? What did we plan? We trained 2,180 health workers and community outreach workers. We managed to have 392, almost 400 fixed points where the polio vaccine will be delivered from. And we have almost 300 mobile teams. Now, this is a massive operation. And the security is paramount. I think the DG has been very clear. We urge all parties to ensure the protection as has been agreed to and discussed, that the parents can bring the children to those fixed points. And in places where that is difficult, we will go with our mobile teams, to reach those children. It's an ambitious target. We need to reach 90% plus. But I think if everything is in place as we discussed, we have a focused community strategy and a community communication strategy, and that's in place as well. So we are really looking forward to start coming Sunday, 3 days in a central everyday analysis. As the DG pointed out, we are almost sure that we will need an extra day, give an agreement for that. We will constantly see where we have to put and place the mobile teams, etc. Then we move to the southern zone and consequently to the northern zone. So yeah, a feasible and a workable approach, etc. And we are all backing this. They're inspiring to see how many people are actually excited about this. We'll push this forward. Of course, these pieces of the puzzle will have to fit together, and we count on everyone on this, all parties, we will count on them. Over to you.
Thank you so much, Dr. Peppercorn. Dr. Tedros?
Yeah, just one line. I think Rick has already covered it very well. What I would like to say is, first of all, we welcome the pause. And second, we hope all parties will respect that. But at the same time, we don't think that pause is enough. And we still insist on a ceasefire because ultimately the best medicine and the best vaccine is actually peace. That's just what I would like to add. And Fadila, back to you.
Thank you, Dr. Tedros. For the second question of Emma, I would like to invite Dr. Deus Mibongizi to answer this question on the emergency use listing for Mpox vaccines. Over to you.
Thank you, Fadila. As the DG mentioned, 2 companies completed their submission of applications to WHO for emergency use listing review on the 23rd. And these are Bavarian Nordic from Denmark and KM Biologics from Japan. There are some other companies that are in discussions, but these are still under screening and we have not yet confirmed their actual acceptance of their submission. So those, at the moment, we are not in position to discuss. Thank you.
Thank you so much. I would like now to invite Agnès Pedrero from Agence France Presse to ask the next question. Agnès?
Yes, hi, good afternoon, everybody. It's a question also on Mpox vaccines. I wanted to ask you if you could be more specific on how many pledges were for DRC, has been made for DRC, and when do you think the first Mpox vaccines could arrive in DRC? Because I heard that before you say that the pledges would materialize in 2-3 months. Would that be not too late, maybe? I don't know. And once the vaccines are available, what kind of logistics difficulties you think the distribution and transportation will face? Thank you.
Thank you, Agnès. I would like to invite Tim Nguyen to answer this question. Tim?
Oh, thank you. So to be clear on some of these pledges, we are in discussion with the partners that are actually donating some of these vaccine, and we have an overview around some of these quantities that will be available in the coming days once the country is also ready to receive and implement these. So what we understand right now is from HERA that they have procured 175,000 doses of MVA-BN vaccine. In addition, the manufacturer Bavarian Nordic is donating another 40,000 doses to these quantities. That makes up about 230,000 doses that we understand are imminently available to be dispatched to affected regions. And then as we look further, subsequently, there are other pledges, but we understand that still needs a couple of weeks for them to be agreed on the final administrative processes to turn pledges into donations. Over.
Thank you. I think that Dr. Van Kerkhove would like to elaborate on this.
Yeah, thanks. So in addition to what Tim was saying about the numbers of doses and when they can get into countries, we're also working with our regional colleagues, our country office colleagues, the Ministry of Health on the vaccine delivery as part of the response. So there are detailed plans that are being developed. This is based on the epidemiology of what's happening in the DRC. There are different modes of transmission. There are different populations that are affected, depending on where we are talking about in the country. And of course, it's not only the DRC. So the plans to use these vaccines in a targeted way are currently being developed. There are plans that exist. But I also want to highlight there's a lot of questions about vaccines, and I anticipate many journalists will continue to ask about the vaccines. But as the DG has pointed out, and as we point out in our Global Strategic Preparedness Response Plan, as is being highlighted in the continental plans, vaccines are only one part of the solution. I was fortunate to be with the Director General in DRC yesterday, where we met with the UN country teams, as he mentioned, and almost as much as they asked about vaccines, they asked about strong, clear communication about prevention, about preventing the spread. How can we have the right messages targeted to the people who are at risk? And so our teams are working with UNICEF, we're working with many different partners. I shouldn't mention one if I don't mention them all, because as WHO, we work in partnership with not just international agencies, but civil society, local partners, to make sure that those messages reach people who are at risk. And so there's a lot of work that's happening there. And I just want to emphasize that right now, even when vaccines aren't available, and it's going to take some time for the vaccines to reach those who are most at risk, the right messages can be reaching the right at-risk populations. So we're working to make sure that those messages are targeted, they're tailored, focusing on prevention, focusing on preventing the spread in the complex context in which these Mpox outbreaks are happening.
Dr. Tedros?
Yeah, thank you. Thank you. So on the vaccines, as you have heard from Deus, one thing that has to be clear is for the EUL, we need complete information. And the information submitted until last Friday was partial. And last Friday, we got from both companies the additional information we were asking for. So we couldn't issue EUL before all the information arrives, because we have to have all the information required before we proceed. On top of that, I think since we have now the complete information, the EUL can be ready in the next 2 weeks, because it's already a week now since we have received the complete information. So, but still, we don't need to wait, until 2 weeks before we proceed with procurements, and that's why Gavi and UNICEF are proceeding with procurements side by side with the process of the EUL. So I think that has to be clear. And then on the vaccines, some of the vaccines, as Tim said, will arrive in the next few days in DRC. While I was in Kinshasa, I met with Minister Kamba and also with Jean Kaseya, the DG Jean Kaseya of Africa CDC. And the things that should be done from Africa CDC side, from the country side, from WHO side, and other partners side has been done. And we hope to have the first delivery in the next few days, and then it will build up. And that's why the October issue that you said, but it's not, I don't think anybody said, the vaccines will arrive in October. The part of the shipment will arrive actually in the next few days, and then will build up. But considering the number of cases and so on, most of the allocation, of course, will be in DRC. And I would like this opportunity to thank the donor countries and institutions for the vaccines, and that will help in our response. But it's not just vaccines alone. We are already implementing the other methods which are very, very important. So vaccine is one among the tools, and we're not just waiting for the vaccines. While expediting the vaccines, we're doing what should be done under the leadership of the government. And the leadership ownership and leadership of governments is important, be it DRC or other countries which I have already outlined that reported Mpox. And not only the ownership and leadership by the governments, but community partnership is also central. Because as we all know, outbreaks start and end in communities. So government's ownership and leadership, strong community involvement and partnership is important. And then the implementation or use of all the tools that we have at hand, including vaccines. One thing that I really commended is the leadership by the DRC government, especially the president, because he put already $10 million on the table to respond without waiting for donors to move. And that's an indicator of ownership and leadership. And that is very, very important to put the resources required while mobilizing partners to supplement to that. That's a major indicator of ownership and leadership. And I hope all countries reporting Mpox will do the same thing. It's only through ensuring government's leadership and ownership that we can stop this virus. Of course, coupled with that, I said, strong community mobilization and appropriate use of the tools, while vaccines would be the additional tool. Fadila?
Thank you. I would like now to invite Gabrielle Emmanuel from NPR to ask the next question. Gabrielle?
Hi, thank you very much. I guess I had a bit of a broader question. One is that, as we all know, there's been a lot of frustration about the time it's taken to get vaccines, Mpox vaccines. And I've heard a lot of people make this analogy that to COVID and the lack of resources then that were in Africa. And I wanted to kind of get a sense of how we're making sure we're not falling into the same pitfalls and hurdles from back then. Also, and not just related to vaccines, but also related to diagnostic tests and other mechanisms to care for what's happening. And then a more specific question, I'm curious, you mentioned about the rising cases. I was wondering if that's happening in specific populations in addition to the countries you mentioned. Thank you very much.
So thanks. I can start with that question. So we're not in the same situation we were in when COVID began. The capacities that countries have, particularly around the world, but particularly in Africa, for diagnostic capabilities, PCR-based capabilities, surveillance, case finding, contact tracing, clinical care, emergency operations centers, across the entire pillars of the response that they expanded and strengthened during COVID, they're using for Mpox, they're using for cholera, they're using for suspect VHF, viral hemorrhagic fever outbreaks. So we're not in the same situation. With regards to vaccines, there's a lot of work that is happening that needs to continue. It was emphasized during COVID to make sure that we not only address access, we not only address delivery and equity, but looking at production capacity, making sure that we have these hubs. We have the mRNA hubs that were started, tech transfer work so that more production can be made for vaccines. So we're not in the same situation that we were. Having said that, Mpox is not a new disease. This virus has been circulating for decades. We went through a global public health emergency of international concern, 2022 to 2023, based on the clade 2 outbreak. We have a new public health emergency of international concern, largely due to this 1B, this new clade. And there's a lot of work that that's happening to not only look at access, but delivery. Another area of strengthened capacity across Africa is vaccine delivery. What countries put together to vaccinate large numbers of people, young through the EPI programs, but all the way through older adults with COVID vaccine, through that life course, can be utilized for Mpox. There's a lot of experience in the DRC itself doing vaccination for Ebola. All of that can be leveraged for the use of vaccines for Mpox. But again, I want to highlight that the use of vaccines as part of this response is part of the response in a targeted way. We're not talking about mass vaccination programs. We're talking about protecting populations at risk, our health workers, contacts of contacts. And again, using those vaccines as soon as they can arrive in country. So I think we need to shift this narrative a little bit and talk about also not only the challenges, but the strengths that exist across the continent of Africa. There's a lot of leadership, as the DG just said, within the country itself, the ownership of this, the capacities in those countries. We are here for support, but this response is led by the ministry, it's led by the government, it's driven by local communities, and we are here to support that implementation of any interventions that are brought in.
Thank you. I would like now to invite next question from Stéphane Bussard, Le Temps. Stéphane?
Good afternoon. Thank you. Yes, my question is, what has been the impact of the polio outbreak so far in Gaza? And are there any other outbreaks that threatens the Gaza Strip? Thank you.
Thank you, Stéphane. These questions are for Dr. Pieperkorn. Are you still with us?
Yes, definitely. I did get the first part of the question. I didn't get the second part of the question. I mean, the first part of the question, the impact.
The second question was, are we seeing also other outbreaks in the Gaza Strip? Not only polio, but other health threats.
Okay, yes, I get your point. Yeah, very good. So first of all, the impact. So as we know, and maybe let me be very clear, we had that confirmed case. And let me also say something about that. The polio case, a 10-month-old boy, which we are monitoring. We maybe just to say for information, as improvement of the child, the movement has improved by 70%, and we're trying to assist with UNICEF, WHO, with cash assistance, and we're following that up. And I think linked to that is surveillance, for example, surveillance and with routine immunization. So when this crisis, we are now in the 11th month of this crisis, and we have seen the health services and the health infrastructure disintegrating. And we have reported on this frequently. With that, it's not just the health services, hospitals, primary healthcare facilities, etc., but it's also the special programs and, for example, surveillance. And surveillance was definitely not what it should be. So together, WHO and the Ministry of Health, after the environmental samples were positive, we specifically focused on that, and that's how we came with these three suspected polio cases, of which one was confirmed. Routine immunization was always incredibly strong in Gaza, at coverages of 90-95%, even over 95%. Of course, when this crisis erupted, etc., the routine immunization also disintegrated. WHO, I would say again, the Ministry of Health, health workers, WHO, UNICEF, and partners, we're focusing on that. And over the last quarter, I mean, reach coverages of almost 90%. We have to get better in the data on the denominator, etc. But it's a lot of focus. How do we get routine immunization improved? Now that links me to the following topic. This is, of course, all in an environment with a disintegrated health sector where you talk about a hospital functionality of 70 out of 36 hospitals, which are partly functional, 58 of 132 primary healthcare, partly functional. In addition, 5 field hospitals, partly in full or fully. And we've seen many an enormous spread of infectious diseases. And when you look at that, for example, acute respiratory infections, and those are underreported. People have lack of access to these primary healthcare facilities. We see more than 1 million acute respiratory infections, more than 600,000 diarrheal diseases, 25 times what is normally there during these kind of periods. A lot of scabies and lice, 105,000, skin diseases, 70,000 cases, and incredibly worrying what we call the acute jaundice syndrome, hepatitis A, over 105,000 cases. A lot of this related to the incredibly poor water and sanitation conditions everywhere in Gaza. So yeah, and it's really, I'm glad that you're asking this question, because we focus now, of course, very much on polio and the polio campaign. But we're deeply concerned about the overall health situation. I talked about the health functionality, and I want to add also another point that over the last week, WHO, the last 2 weeks, we planned for 6 missions to the north to bring fuel, to bring medical supplies to the hospitals in the north. Only 2 were approved to deliver those fuel and medical supplies. And with huge troubles, I mean, incredibly lengthy missions. One of our teams only returned late at night, completely unnecessary. Day before yesterday, so WHO reached the Indonesian hospital with fuel, and also part of fuel were to Kamal at 1. But other hospitals in the north, like Al-Ada Hospital, they face 0 fuel stocks. And that has, of course, implications for all their services, the maternity services, the daily surgeries, which they do, the hemodialysis patients, etc., and other hospitals, HELU hospitals, international hospitals, facing same problems. And it really pains me that in the 11 months of this crisis, we still have to discuss these basics kind of missions of fuel and medical supplies, bringing teams, emergency medical teams in, bringing patients in and out. And we still struggle with that. And related to that, also another topic is medevac. The medical evacuation is incredibly needed. We estimate that 10,000 critical patients should leave Gaza. They should get treatments elsewhere, outside Gaza. And since the Rafah crossing closed on 6 May, the only substantial medevac was organized with great support from the UAE, and WHO managed and organized to actually facilitate the medevac of 85 patients and I think 65 companions. But that's, of course, a drop in the ocean, what is needed. And we request, and I want to do this again today, we request the establishment of medical corridors, first and foremost, to restore the traditional referral paths from Gaza to East Jerusalem and West Bank. Hospitals already in the West Bank and East Jerusalem to receive Gazan patients, to receive their Palestinian brothers and sisters. Then also to get a medical corridor operated to Egypt and to Jordan. So this is just some of these issues. Thank you. Over to you.
Thank you, Dr. Peppercorn. I can see that Dr. Hamid Jafari wants to add some details. Dr. Jafari, you have the floor.
Thank you, Fadila. And just to supplement what Rick has said in terms of the impact, and I think for polio, we have to actually think about the potential impact the current outbreak has. So we know that this virus came into Gaza probably around September, October of last year, and it has been circulating in Gaza since then. And just the genetics, genomic signatures on the virus, and that it's been detected in multiple sites, and now we have a unfortunate paralytic case of polio. We are assuming that this virus is circulating all across Gaza. And the conditions that Rick and others have described of lack of clean water, overcrowding, extensive sewage contamination are ideal for intense poliovirus transmission. So the potential for this to continue in Gaza, spread to surrounding countries. Israel has communities that are reluctant to vaccinate for religious reasons. Lebanon is going through a crisis. there are issues in Syria. So there is a fair amount of vulnerability in the surrounding countries. And so the potential for international spread, and that's why polio, I want to remind everybody, remains a public health emergency of international concern under the IHR. So I think we need to think about this as what are the potential impacts of more paralytic cases in Gaza, and then international spread with other countries having to declare public health emergencies and stopping outbreaks and preventing paralytic cases within their own borders. Back to you, Fadila. Thank you.
Thank you, Dr. Jafari. I would like now to ask if other colleagues want to add anything. Maybe Dr. Zakaria?
Thank you, Fadila. Just to highlight that it has been 11 months of continued violence. And so we're seeing now polio, but this is along with many other diseases for which our collective capacity to prevent, detect, and respond to continues to be disrupted, severely disrupted. We have not been able to implement the most basic public health interventions for the entire population of Gaza, and people continue to be displaced, people continue to not having access to sufficient and good quality food, especially for the younger children who depend on much more than food commodities getting into Gaza. So we're seeing polio, but we're also sure that many other pathogens are spreading undetected. And it's a matter of time until we see a surge and many more diseases spreading really out of control. What we wish, though, is for this polio vaccination campaign to be successful, which would also be then an important milestone for us to know that, yes, humanitarian operations can be scaled up for the entire population of Gaza. And the vaccination against polio for Gaza should then set the example for how we can do better and significantly increase humanitarian assistance for all sectors for the entire population of Gaza, and also the West Bank and the region. Thank you.
Thank you so much. I realize that we haven't answered one of the questions from Gabriel Emmanuel from NPR on rising cases of Mpox. We have with us Dr. Rosamond Lewis, and Rosamond is our technical lead for Mpox. Dr. Lewis, do you want to take NPR question on do we have rising cases of Mpox?
Thank you very much. Yes, it's certainly a valid question. And there are rising number of cases being reported in different parts of the country. So you've heard, of course, that there's the cases in the endemic areas, largely affecting children, young children and adolescents as well. And then we also have the fairly rapidly spreading outbreak in the eastern part of the country, which is now also in Burundi, with cases in Rwanda, Uganda, and Kenya. So there is suggestion that, of course, these outbreaks are continuing to spread, and there are true virus. For example, in the eastern part of the country, it really started in one health zone called Kamituga, and then it spread to 10 health zones in South Kivu, and then it spread to North Kivu, and then it's clearly the virus is on the move, and those are true cases. Another factor is, for example, notably, well, in both outbreaks, endemic areas as well as in the outbreak that began in East and Central Africa, is the attraction to improving health services. Part of, you've heard Dr. Van der Kolk say that we support the countries on many aspects of the response. One of them is providing essential medicines kits for clinical care, particularly for children, but also for adults, for hospitals and health centers. And so as the population realizes that they in fact have access to better optimal care, they will also come to the health centers, and so more cases are detected. You also have an increase in access to diagnostics. You also very specifically mentioned that. While the emergency use listing has been triggered 3 weeks ago, and the public health emergency of international concern 2 weeks ago, of course, we've been supporting the country ever since they first declared, well, even before that, naturally, but remember, the Democratic Republic of the Congo declared their epidemic of Mpox as long ago as December 2022. So since that time, we've been bringing support, and notably over the last 8 to 10 months in diagnostics, including increasing the capacity for diagnostics from 1 national lab to 8 provincial labs, 2 national labs that can now do polymerase chain reaction, PCR, and 8 provincial labs or 7 provincial labs that can also do PCR, but through a smaller unit called GeneXpert, which is provided to provincial labs. So diagnostic capacity has increased a lot, which means, again, people have better access to diagnosis and access to care because of that, and confirmation, which also increases the number of cases reported. So there are many things that are contributing to increase a number of cases. So better surveillance, better diagnostics, better clinical care, actual circulation of the outbreaks, which continues. And with all of that, we're working also with the country to improve case definitions. So, for example, in the early days when the outbreak first began in South Kivu, and 1/3 of the cases were in fact among sex workers, at that time, sexual transmission of Mpox was only just becoming recognized in the country. And so it took some time to also recognize that genital lesions, for example, could be Mpox as opposed to herpes or syphilis. So quite a number of factors are contributing to a greater recognition of the disease. And as we continue to support the country in all these areas of work, of course, we do expect the number of cases to continue possibly to rise, although we've done a lot already. And then with time, as the interventions take more and more effect and better hold, we fully expect the number of cases to begin to come down again. Thanks.
Dr. Van Kerkhove?
Yeah, I just wanted to, Rosamond was reminding me of, she made some great points. I just want to highlight a couple of things here. So when you see these maps, we've seen these maps online that show cases in circulation. They basically color the whole map. And what we're trying to do with the detailed epidemiology and working with the different teams is really looking at a more granular level about what's happening. So as Rosamond was saying, it's very complex. There's a lot of different groups that are affected, but not all the same groups are affected in the same areas. There's different clades that are circulating. We have some information on occupation. We see different age profiles. And so what we're hoping to be able to do through the strengthened IMSTs in country, working with the ministries of health, working with partners, is to have more details of that epidemiology. Because the more precise we can be, the more targeted we could be in tailoring the interventions. Everything from enhancing the surveillance that we're doing through the risk communication and the targeted messages there, through the use of those vaccines. So I just wanted to highlight that point, that the surveillance aspects that's been pointed out already are really critical. And the upsurge of staff in people, workforce in the DRC, led by the Ministry of Health, led by the government, part of that is really trying to get that detail. So we're really grateful for all of the extra hands on deck that have a lot of experience with surveillance in the country to help us really detail this out, because that precision is what we need to really stop this outbreak in the next 6 months.
Thank you so much. I would like now to invite for the last question, Hailey Ott from CBS. Can you hear me?
Hello, thank you. My question is about the polio vaccine in Gaza. Health workers in Gaza have raised concern over the cold chain. The Palestinian Ministry of Health says there will be mobile refrigeration units. I was wondering if you could give us any more information about those and how they would work and how the cold chain would be maintained and managed during vaccine delivery and distribution. Thank you.
Thank you. Maybe Dr. Jafari can take this question.
I can start and then Rick can provide additional details. So the way the cold chain is organized is that this is largely a fixed site vaccination with some outreach. There was a shortage of cold chain, and so additional freezers and refrigerators have been imported by UNICEF and deployed into Gaza. From these freezers, the vaccine is then put into cold boxes and brought closer to the vaccination sites, where then it is transferred to a large number of vaccination teams in what we call vaccine carriers to maintain the integrity of the cold chain. So the planning and positioning of cold chain is part of what we call micro planning for this campaign, which has been completed. And then, of course, a very important tool that exists is the vaccine vial monitor, which is on every vaccine vial of polio, that tells the vaccinator and health workers about the viability of the vaccine, that monitor is a very strong tool. So, Rick, I don't know if you want to add any particular specifics on how this is being managed in Gaza?
Yes, thank you, Amit. Yeah, I would like to add some points and thanks for this question. So, first of all, I think we described the number of vaccines which have arrived in Gaza, and actually all the cold chain equipment, including I would say generators and related to that. So it's all part of that. And you talk, for example, about 500 vaccine carriers, etc. I mean, Hamid describes already the fixed sites, and I will again point that out. We talk about almost 2,180 health workers, community outreach workers, which have been trained and will support implementing of this campaign. And we talk about 392 fixed points. I mean, and they are there. So the vaccines, cold chain is one issue. Then we talk about fuel, for example, that it is needed to make sure that this all works. That's all been arranged with all kinds of difficulties. We discussed a number of days, the way we actually going to implement the campaign, the 3 days per zone, plus when needed another one, the mobile teams. And just the word micro planning is sometimes a bit, I think it doesn't do justice. The micro planning is the most important part of any polio campaign, and it seems easy, it's actually very complex. So it's like area by area, small area by area. What's the analysis? Where are the children? How do we vaccinate? What's the best way forward? And this is constantly being updated and adapted. And when we talk about, because I think I was not even clear enough how complex it is, even in a place like a relatively small environment as Gaza, the total number of teams is 513. Yeah, we fixed teams, 174 fixed teams, outreach, 252. We talk about community points, 33 community points, 252 mobile teams, special 48, transit teams, as we call it, 39 transit teams, and backup teams, 40. Now that shows a little bit about the complexity of this operation. And I also want to stress that it's also part of vulnerability of this operation. And we have to make sure that's all part of all the puzzles. I mean, everybody talks always about the vaccine and the cold chain, which is very important. The micro planning and everything related to that is probably the most important part of a successful campaign. And this brings me back and that we need, of course, we need definitely that all the parties actually, that we stick to the agreement we have, the humanitarian pauses, to ensure that people can move, that they can bring their children, that all those teams can do their work. We talk about hiring vehicles, hiring tuk-tuks, motorcycles, etc. It's all part of the campaign. When this is all linked, I think we have a good chance to actually get a successful campaign. So again, we call on all parties to help ensure that this happens as it is being planned and agreed on. Over to you.
Thank you, Dr. Jafari, and thank you, Dr. Pieperkorn. We have come to the end of our press conference. Thank you so much for your participation. We will be sending you the audio files and Dr. Tedros' remarks right after this briefing. And of course, you can reach out to the WHO media team if you have any follow-up question. With this, over to you, Dr. Tedros, for your closing remarks.
Thanks, Fadila. And thanks to all members of the press for joining us today. And see you next time.